Hi students, continuing the series of DUM Lagaa ke Hayishaa, let's continue with Megaloblastic Anemia. In our last lecture, we have already dealt with iron deficiency anemia. तो हमने आयरन डेफिशिएंसी एनीमिया के अंदर क्या बहुत इंपॉर्टेंट पॉइंट्स पढ़े थे, क्विकली रिवाइज कर लेते हैं. दैट इट इज अ कॉज ऑफ माइक्रोसिटिक हाइपोक्रोमिक एनीमिया, है ना. आयरन डेफिशिएंसी एनीमिया में माइक्रोसिटिक हाइपोक्रोमिक टाइप ऑफ एनीमिया दिखता है, मतलब एमसीवी लेस देन 80 फेम्टोलीटर होता है. व्हाट इज द नॉर्मल एमसीवी? Yes, it is 80 to 100 femtoliter. तो अगर लेस देन 80 फेम्टोलीटर होगा तो माइक्रोसाइटोसिस होगा. वहीं पे अगर इफ इट इज मोर देन 100 फेम्टोलीटर, दैट विल बी अ कॉज ऑफ मैक्रोसिटिक एनीमिया. ठीक है, तो अब हमने 4 इंपॉर्टेंट कॉजेज ऑफ माइक्रोसिटिक हाइपोक्रोमिक एनीमिया कौन से पढ़े थे? वी रिमेम्बर्ड विद द हेल्प ऑफ निमोनिक सीता. ठीक है, सिड्रोब्लास्टिक एनीमिया, आयरन डेफिशिएंसी एनीमिया, थैलेसीमिया माइनर एंड एनीमिया ऑफ क्रॉनिक डिजीजेस. और इनमें हमने वी स्टडीड अ लॉट ऑफ पॉइंट्स कि हाउ कैन वी डिफरेंशिएट दीज 4 इंपॉर्टेंट कॉजेज ऑफ लो एमसीवी, एमसीवी लेस देन 80 फेम्टोलीटर. ठीक है, नाउ लेट्स क्विकली कम टू एमसीवी मोर देन 100 फेम्टोलीटर. ठीक है, तो अगर आपके पास एक पेशेंट आता है विद टिपिकल फीचर्स ऑफ एनीमिया, ठीक है, वीकनेस, टायर्डनेस, पैल्पिटेशंस, ये सब रहता है, टिपिकल प्रेजेंटेशन ऑफ एनीमिया रहता है, आप क्या कराएंगे? सीबीसी कराएंगे. सीबीसी में यू विल लुक एट द वैल्यू ऑफ एमसीवी. If it is less than 80 femtoliter, you classify it as microcytic anemia and you start ruling out 4 important causes of microcytic hypochromic anemia. You can memorize with the help of mnemonic सीता. नेक्स्ट आता है, अगर एमसीवी 80 to 100 femtoliter होता है, then it would have been normocytic anemia. In fact, a very important cause will be anemia of chronic disease here as well. Right now, next our main topic of today is मैक्रोसिटिक एनीमिया. तो मैंने देखा एनीमिया का पेशेंट है, मैंने सीबीसी कराया एंड माय एमसीवी कम्स आउट टू बी मोर देन 100 फेम्टोलीटर. नाउ आई नीड टू सी what is the reason for this macrocytic anemia. Now it could be due to underlying megaloblastic anemia or non-megaloblastic causes of macrocytic anemia. Now let's quickly enumerate the important causes of non-megaloblastic anemia. You can memorize with the help of mnemonic. My liver bleeds a lot. So my is MDS, which is obviously a diagnosis of exclusion. So you basically exclude the other causes and then you come to make a diagnosis of MDS, right? MDS we will be dealing with later. Now liver. So my for MDS, liver, that means some liver disease. Bleeds means hemolytic anemia. This is a very important cause of macrocytic anemia because there will be increased retic count, polychromatic RBCs. So increased retic count in a patient of increased MCV, yes, you should make an important diagnosis of hemolytic anemia, right? So in hemolytic anemia, yes, MCV will be high, but the retic count will also be high. Retic count will be high. Next, you will see alcoholism and low thyroid or hypothyroidism. So these are the important causes of non-megaloblastic causes of macrocytic anemia. Coming to a diagnosis of megaloblastic anemia, we will be discussing in detail how do you come to make a diagnosis of megaloblastic anemia. But here definitely few points here will be MCV will be more than 100 femtoliter definitely, but the retic count will be low, right? Retic count will be low, very very important. Right, this is a state of ineffective erythropoiesis, right? Megaloblastic anemia could be due to underlying vitamin B12 deficiency, folic acid deficiency. MCV will be more than 100 femtoliter, but the retic count will be low in megaloblastic anemia, unlike a case of hemolytic anemia. Now let's quickly describe megaloblastic anemia in detail, how you make a diagnosis of it. So typically the clinical presentation will be, yes, the patient will be coming with the features of anemia. Now, what are the features of anemia, students? Yes, weakness, tiredness, associated palpitations, right? Mild jaundice can be there because there can be some underlying breakdown of RBCs as well. So, features of anemia, mild jaundice can be there in this patient. Now, what are the features they can give you? Yes, apart from features of anemia, they can give you hyperpigmentation of knuckles, which can help you make a quick differential of vitamin B12 deficiency. So hyperpigmentation of knuckles, right? These are all your previous MCQs. Hyperpigmentation of knuckles, or they can give you a red beefy tongue, right? Again, these are the clinical presentation that can help you think of a diagnosis of megaloblastic anemia. Now you will quickly order for a CBC, complete blood count. What will you see here? Yes, definitely hemoglobin will be low. No doubt about it, this is anemia, so low hemoglobin will be there, right? So what will happen to MCV? yes, MCV will be high. So we have already discussed normal MCV is 80 to 100 femtoliter, but here MCV will be more than 100 femtoliter. So suppose they say that a vegan, a very important hint in your question, yes, in your clinical feature, one will be, yes, the vegetarian diet. In fact, these days, the veganism, because what are the rich sources of vitamin B12? Non-veg and dairy products, right? So if there is a deficiency of both in a vegan diet, they are highly prone to develop vitamin B12 deficiency. And vitamin B12 deficiency will be presenting to you, apart from anemia, what other presentation will be there? Tingling sensations. That means neurological signs, neuro-associated neuropathy, tingling sensation in hand and feet. So this is the typical presentation that a vegan or a vegetarian coming with tingling sensation or a red beefy tongue or hyperpigmentation of knuckles. These all hints can help you make a quick diagnosis of vitamin B12 deficiency. But on laboratory analysis, yes, MCV will be high, very important. What will happen to MCH? It will be increased, because here you see the RBCs which are large in size, oval in shape, macroovelocytes, and the central pallor is less only, right? So MCH is also high. Now what will happen to MCHC? It is actually MCH by MCV ka ratio. So because both are increased, your MCHC ratio remains normal, right? It remains normal. So yes, MCV will be high, MCH is high, MCHC is high. What will happen to retic count? Very important, is one of the important causes of low reticulocyte count, right? Low reticulocyte count. Okay, so till now we have studied MCV will be increased, MCH increased, MCHC normal, right? Retic count increased, right? Definitely you will also order for a peripheral blood film. Now what are the important findings? Very important on PBF. Yes, number one will be, because there is MCV is high, that means macro and ovelocytes. So macroovelocytes are seen on peripheral blood film finding, right? So they will be large and less central pallor will be there. So macroovelocytosis, along with that, very important, hypersegmented neutrophils. Now what is the first finding you will see in a patient of vitamin B12 deficiency? Macroovelocytosis, right? Macroovelocytosis. Now let's quickly see how do you make a diagnosis of hypersegmented neutrophil. So either 5 or more than 5% neutrophils with more than 5 nuclear lobes, or even if single neutrophil with 6 or more than 6 nuclear lobes. मतलब एक भी न्यूट्रोफिल में अगर आपको 6 या 6 से ज्यादा 6 or more than 6 nuclear lobes मिल जाते हैं, you can categorize it as hypersegmented neutrophil. So 1, 2, 3, 4, 5, 6. Right, in fact 7. So this is a hypersegmented neutrophil. So macroovelocytosis plus hypersegmented neutrophil, right? Along with that, what other finding will you see in a peripheral blood film of a patient suffering from megaloblastic anemia? Thrombocytopenia, matlab low platelet count, low thrombocytopenia, low platelet count. So ये सब features if you are able to see in your peripheral blood film. Along with that, you can see these Howell Jolly bodies. Yes, let me zoom into the image. These are the hypersegmented neutrophils, right? What is the definition of hypersegmented neutrophil? 5% or more than 5% of neutrophils with 5 or more nuclear lobes, or even if one single neutrophil with 6 or more than 6 nuclear lobes, you can categorize it as a hypersegmented neutrophil. So macroovelocytosis, hypersegmented neutrophils, thrombocytopenia, मतलब platelet का count भी कम है, you can come to a diagnosis of megaloblastic anemia. Right, along with that, you can see here that these are the nuclear DNA remnants, right? These are the inclusions seen within the RBCs. These are the Howell Jolly bodies. Along with that, you can see few teardrop RBCs as well. So these are the peripheral blood film finding, right? Peripheral blood film finding. Okay, so let's come to all the main important points. So what we have seen is, yes, MCV will be high, right? So it will be more than 100 femtoliter. This is very important. Along with that, MCH will be high as well. What will happen to MCHC? Because this is a ratio of both, right? Because both are increased, so it will cancel out and it will remain as a normal ratio. Along with that, reticulocyte count will be low, right? It will be low compared to a case of hemolytic anemia. So versus hemolytic anemia where the retic count will be high. Along with that, I told you that mild jaundice can be there. Why is jaundice there? Because a breakdown of RBCs can occur in some cases, which will lead to increased LDH. So serum LDH may increase in some cases. Okay, so let's come to the other laboratory values, because here vitamin B12 deficiency. So serum vitamin B12 will be low. What is the normal level of serum vitamin B12? It is usually, normal is more than 280 picogram per ml. So here the B12 levels will be low. Serum vitamin B12 level will be low. Now students, let me tell you few important functions of vitamin B12, with the help of which we will see a lot of findings in a case of megaloblastic anemia. So normal functions of vitamin B12. Right, so what is the main first function? Very, very important, because of which, right, there is a defect of nucleus and thus nuclear cytoplasmic asynchrony in a patient of megaloblastic anemia. So the main function of vitamin B12 is conversion of uridine monophosphate into, right, thymidine monophosphate. Now this step requires the presence of vitamin B12, and because this thymidine, right, this thymidine monophosphate will lead to formation of thymidine required for incorporation into the DNA and the DNA maturation, right? So DNA formation and maturation में कौन सा factor involved होता है? Thymidine, right? Thymidine. Now along with that, students, if you allow me, I can explain one more important point here. We will also discuss about folate trap here. Now, what do you mean by folate trap? This is a very important question. They often ask that folate trap can be seen in which of the following deficiencies. So it is seen in vitamin B12 deficiency. Why? Now, let me quickly tell you few biochemical reactions. You must have studied under your biochemistry, but we will quickly study here to understand the manifestations of vitamin B12 deficiency here. So, what happens is basically, what is the role of this tetrahydrofolate? So normally what happens is this homocysteine is there, right? Another function of vitamin B12, homocysteine is converted into methionine, and that is in the presence of methylcobalamin. Methylcobalamin acts as a donor of methyl group, here, and itself in turn takes this methyl group from the N5-methyl tetrahydrofolate. ठीक है, तो यहाँ से ये अपना मिथाइल ग्रुप ले लेता है और फिर इन रिटर्न बनाता है tetrahydrofolate, which is actually required for this step, for the incorporation of this tetrahydrofolate and resulting in the formation of थाइमिडीन हियर. तो इस स्टेप में क्या जरूरी होता है? टेट्राहाइड्रोफोलेट जरूरी होता है. So if you understand this basic thing, I will just enumerate कि homocysteine से methionine बनता है in the presence of methylcobalamin. यहाँ पे ये methylcobalamin acts as a source of methyl group and in turn takes the methyl group from N5-methyl tetrahydrofolate. ठीक है, तो अगर ये आपका जो विटामिन B12 है वो नहीं है, so suppose there is a vitamin B12 deficiency है ना, तो ये जो tetrahydrofolate है that's also gets entrapped, ठीक है, entrapped in this N5-methyl tetrahydrofolate. That actually it is trapped. So this is the folate trap which occurs here in a case of deficiency of vitamin B12. तो उससे क्या क्या हुआ? Number one, yes, serum homocysteine बढ़ गया. तो can I say serum homocysteine will be increased in this patient? Definitely. So one of the laboratory findings and an important indicator of B12 deficiency is that your serum homocysteine will be increased, right? Because of which it will not be getting converted into methionine, and the folate trap does not allow the formation of thymidine, which is required for DNA maturation. Thus DNA maturation cannot take place. So DNA maturation हुआ ही नहीं, doesn't take place, and thus this nuclear defect doesn't take place. Now you must be thinking that there is no nucleus inside RBC. Yes, mature RBC does not have a nucleus. This is correct representation. Mature RBC doesn't have a nucleus, but the precursors, the erythroid precursors, right, will have the presence of a nucleus, and because the nucleus is not getting matured here, but the cytoplasmic maturation is normal, So can I say that nuclear maturation is lagging behind, but the cytoplasmic maturation is normal? So can I say there is nucleocytoplasmic maturation asynchrony? Now this is an important terminology. Nucleocytoplasmic maturation asynchrony. Nucleus नहीं mature हो पा रहा है, cytoplasm तो अपना mature हो ही रहा है. Why is nucleus not able to get matured? Because of the deficiency of thymidine. Because the entire folate trap is taking place. तो अभी तक क्लियर है. सीरम होमोसिस्टीन बढ़ गया है, फोलेट ट्रैप हो गया है. फोलेट ट्रैप इज सीन इन विटामिन B12 डेफिशिएंसी. थायमिडीन नहीं बन पा रहा है, इनकॉर्पोरेशन इनटू डीएनए मैच्योरेशन नहीं हो पा रहा है ना. तो in fact a lot of findings you see in your bone marrow, megaloblasts are seen because they are immature and they are characterized by sieve like open chromatin because of defect of DNA maturation. ठीक है, तो अभी तक ये क्लियर है. Now before coming to skilling test, we will again study. So two functions we have dealt with. Third function, can you quickly tell me? Yes, what is the function of vitamin B12? Now another important function is that it results in the formation of succinyl CoA. ठीक है, तो succinyl CoA कहाँ से बनता है? Methyl malonyl CoA. Methyl malonyl CoA से बनता है आपका succinyl CoA. And this step also requires the presence of vitamin B12. तो अगर विटामिन B12 का डेफिशिएंसी होगा, that means methyl malonyl acid, right? Methyl malonyl acid will be getting accumulated in blood, so that will lead to methyl malonemia, or also in urine it will be excreted out, so methyl malonyl aciduria. So here the concentration of serum homocysteine and serum methyl malonic acid will be increasing in a case of vitamin B12 deficiency. तो अपार्ट फ्रॉम सीरम विटामिन B12 जो कम हो जाएगा, नॉर्मल था नॉर्मल वाज मोर देन 280 पिकोग्राम पर ml, तो वो डेफिनेटली लेवल्स कम हो जाएंगे. Along with that, important indicators of a vitamin B12 deficiency will be serum homocysteine increase होगा, right? Serum methyl malonic acid will be increased in blood as well as urine. It will be increased. ठीक है, तो ये सब important findings है. Apart from that, because this is incorporated into your neurolipids, right? Because this is required for the formation of myelin sheath, तो ये भी defect हो जाएंगे. ठीक है, because of the defect of the myelin sheath formation, because of the defect of the lipids incorporation into the myelin sheath, the patient will be suffering from neuropathy. So what is the important clinical manifestation of vitamin B12? It is the development of neuropathy because of the defect of this step of conversion from methyl malonyl CoA to succinyl CoA. ठीक है, तो अभी तक सारे important functions along with their laboratory manifestations, is it clear? So students, till now we have discussed all the important aspects. Let me just quickly come to the aspect of peripheral blood film finding in a case of megaloblastic anemia. Let's quickly revise. Very important. Number one, macroovalocytosis, the first characteristic finding in a case of megaloblastic anemia. Number two, hypersegmented neutrophils. Now here you can see how many lobes are there. Definitely more than 6 nuclear lobes are there. This is a hypersegmented neutrophil. So macroovalocytosis plus hypersegmented neutrophils. Along with that, you can find some Howell-Jolly bodies or teardrop RBCs, and very important, thrombocytopenia will be seen on a peripheral blood film, right? Thrombocytopenia, decreased platelet count. Now let's come to a very important aspect of diagnosis of megaloblastic anemia. It is the bone marrow aspiration, where you will see a hypercellular bone marrow. So a hypercellular bone marrow will be there with the erythroid hyperplasia, because we are trying to compensate erythroid hyperplasia because we are trying to compensate for the anemia. So there will be increase in the erythroid series of cells. So normally M/E ratio is 3:1. That means normally the myeloid series of cells are more in number, but here there is a reversal and we are trying to compensate for the underlying anemia. Thus there is an increase in the erythroid series of cells, and thus there is a reversal of M/E ratio. Now what happens even if there is a hypercellular bone marrow with the erythroid hyperplasia, but the retic count is low? In fact, if you remember, this is an important point to differentiate a case of megaloblastic anemia from hemolytic anemia. So retic count being low, even after being there occurring a erythroid hyperplasia or a hypercellular bone marrow, this indicates that this is a case of ineffective erythropoiesis. Now what will you find in a case of megaloblastic anemia? So number one, you will see that the large size cells, megaloblast, so large sized immature or precursors of RBCs will be there, definitely. Number two, there is a defect in the maturation of nucleus. Now remember the pathogenesis. Vitamin B12 was required for formation of component thymidine, which needs to be incorporated into DNA and cause the maturation of nucleus. But there is a deficiency of B12, defect of thymidine incorporation, defect of nuclear maturation, and thus nuclear cytoplasmic maturation asynchrony. The cytoplasm is getting mature normally. Cytoplasm तो अपना mature हो रहा है. क्या मेच्योर नहीं हो रहा है? न्यूक्लियस मेच्योर नहीं हो रहा. क्यों नहीं हो रहा? क्योंकि उसमें थाइमिडीन कंपोनेंट को इनकॉर्पोरेट करना था, बट दैट इज नॉट बीइंग फॉर्म ड्यू टू अंडरलाइंग विटामिन B12 डेफिशिएंसी. तो डीएनए मेच्योरेशन डिफेक्टिव है, ठीक है, बट साइटोप्लाज्मिक मैच्योरेशन तो नॉर्मल हो रहा है. सो देयर इज न्यूक्लियर साइटोप्लाज्मिक मैच्योरेशन एसिंक्रोनी बिकॉज द न्यूक्लियस इज नॉट एबल टू गेट मैच्योर्ड प्रॉपर्ली इन सम immature features. What are the immature features? Yes, you can see here that the nucleus is immature, right? It is showing open sieve-like chromatin. Open sieve-like chromatin indicating the immaturation of nucleus, but the cytoplasm is getting matured normally, right? So I hope it is clear. Megaloblast will be seen. Along with that, you can find some giant metamyelocytes and band forms in a case of megaloblastic anemia on bone marrow aspiration, right? So let's quickly come to the aspect of what all can be asked from folate deficiency. Now, if you remember the concept of folate trap, which occurs in vitamin B12 deficiency, and thus in a case of B12 deficiency, along with B12, you should also give folic acid, right? So that is one scenario. Number two, very important, is that the neurological manifestations which are seen in underlying B12 deficiency are absent in isolated folate deficiency. ठीक है, तो अगर neurological manifestations दिया है तो what is it pointing towards? It is pointing towards a case of B12 deficiency and not an isolated folic acid deficiency. Now third important aspect is what will happen to serum folate levels. It will be decreased. कम ही होगा ना, क्योंकि folic acid deficiency है तो folic acid level कम होगा. Number 4 point will be RBC folate level. देखोगे that will also be low. RBC folate level is low. And fifth point is FIGLU excretion test. So what will happen is this excretion product in urine will be increased. Why? Why? Because histidine dose, if you give a histidine loading dose, what happens is it is converted into glutamate and it requires the presence of tetrahydrofolate in this step. But what happens in case of folate deficiency? This step does not occur and it stops at an intermediate level where the levels of FIGLU, forminoglutamic acid levels, will be increased. This will be excreted into the urine and thus this is used as one of the method for the diagnosis of folate deficiency, right? So you remember all the important points. You remember the concept of folate trap. Neurological manifestations will not be seen in an isolated folic acid deficiency. FIGLU excretion in urine will be increased, right? So till now it is clear. Now moving on to the next, we will quickly see what is pernicious anemia. Now to understand the concept of pernicious anemia, it is important to understand how vitamin B12 was getting absorbed. So how is it getting? Once you ingest vitamin B12, so this is a person, right, who is ingesting, suppose let me make a diagram, right? So this person is ingesting B12. Now that is predominantly in the non-veg diet or the dairy products, right? So therefore veganism, people who are vegan or vegetarian will have a history of B12 deficiency in most of the cases. So once ingested, right, so what will happen? There are salivary glands that will release certain proteins called as heptocorin or transcobalamin 1, right, that will bind to this vitamin B12 and then it will go into your stomach. So in the stomach, what will happen? There are parietal cells, which is an important source of intrinsic factor along with hydrochloric acid. It is an important source of intrinsic factor. So this intrinsic factor is released. Now this vitamin B12 bound with transcobalamin will be passing into the intestine, right? Along with that, the pancreas acting as a source of certain proteases that will cleave these proteins and will liberate the vitamin B12. So this vitamin B12, once it enters into the duodenum, that is the proximal small intestine, right, this vitamin B12 will now bind to intrinsic factor. This is very, very important. Why? Because only this combination can get absorbed in your terminal ileum. So if you remember the mnemonic, IFB, right? This is the company, electronic company, and based on the parts of the small intestine, what comes first? Duodenum. then comes jejunum, and then comes ileum. Right, so it is the B12 which gets absorbed in the ileal enterocytes. So what will happen? This combination once enters into the ileum aspect, this ileal enterocytes, right? This ileal enterocyte will have certain receptors called as the tubulin receptors, to which this intrinsic factor binds, right? So intrinsic factor receptors or the tubulin receptors are present on the ileal enterocytes, through which this combination can get absorbed. That means if suppose there is any defect, there is atrophy of the stomach due to which this parietal cell gets atrophied and does not release this intrinsic factor, that means vitamin B12 अकेला रह जाएगा, and अकेला vitamin B12 तो ileal enterocyte में cannot be absorbed. It requires to be attached to intrinsic factor because it is the intrinsic factor receptors or the tubulin receptors on the ileal enterocyte जिस जहाँ से combination करके B12 absorb होता है. तो एक बार ये vitamin B12 absorb हो गया into the circulation, now it gets transported with the help of a protein called transcobalamin 2. ठीक है, तो अभी से circulation से it will enter into kidneys also, और kidneys में ये excrete हो जाएगा. ठीक है, तो अब kidney में जो excrete होता है, this is the basis of Schilling test. Now what is Schilling test we will discuss, but I hope you understand in pernicious anemia it occurs due to any atrophy of parietal cells or any antibodies against this intrinsic factor. So this deficiency of intrinsic factor is again a very important aspect of development of vitamin B12 deficiency. So I hope it is clear. If intrinsic factor is absent or it is atrophied, parietal cells are atrophied, finally intrinsic factor cannot bind to B12 and thus it cannot be absorbed, right? Now what is Schilling test? Now this is important in order to differentiate what is the cause of B12 deficiency. So what is the cause of B12 deficiency? Right, now what will happen? You will treat a patient of B12, give a proper dose of B12 to a patient, and after some time you will see that if the patient is getting corrected. Suppose even after the treatment taken, B12 supplements taken, the patient is not getting treated, that means you need to suspect the underlying intrinsic factor deficiency. तो क्या होता है बेसिकली इसमें आप रेडियो लेबल्ड आप, तो ये बेसिकली क्या है, टू सी वेदर इट इज ड्यू टू अंडरलाइंग इंट्रिंसिक फैक्टर डिफेक्ट और डेफिशिएंसी और नॉट. ठीक है, तो आप रेडियो लेबल्ड B12 देते हो ओरली, राइट. उसके 1 घंटे बाद यू विल गिव अ नॉन लेबल्ड रेडियो लेबल्ड B12 IM इंजेक्शन. ठीक है, तो आपने क्या किया, आपने B12 दे दिया. Now what will happen after 24 hours? You will take the urine sample. ठीक है, अब इस urine sample में if the patient is normal, right, there will be more than 8% radio labeled B12 excreted. More than 8% radio labeled B12 in your urine. But what happens is if there was a defect in intrinsic factor, ये 8% नहीं होगा, it will definitely be less than 8%. So what will you do? Stage 2, next step will be that you will now give you will add an oral dose of intrinsic factor now. अब ये intrinsic factor देने के बाद अगर आपका जो यूरिन में एक्सक्रीशन था of this radio labeled B12, ठीक है, ये देने के बाद सप्लीमेंट करने के बाद ओरली अगर अब ये मोर देन 8% हो जाता है, दैट मीन्स इट वाज ड्यू टू अंडरलाइंग इंट्रिंसिक फैक्टर डेफिशिएंसी. इसमें और स्टेजेस भी आते हैं, अगर तभी भी ट्रीट नहीं होता देन यू कैन जस्ट ऐड एंटीबायोटिक. अगर आप इसमें एंटीबायोटिक का डोज दे दो, उसके बाद फिर आपने यूरिन सैंपल देखा, अब जाके अगर मोर देन 8% हो जाता है, सो इट कुड बी ड्यू टू बैक्टीरियल ओवरग्रोथ, जिसकी वजह से वो खुद कंज्यूम कर रहा था और B12 deficiency क्रिएट कर रहा था. So there are multiple stages, but mainly what you need to remember is the Schilling test is used to differentiate or find out the cause of underlying B12 deficiency. तो normally तो more than 8% radio labeled B12 should have come into the urine, but अगर नहीं आ रहा है then you are adding oral intrinsic factor and then seeing if अगर अब increase हो जाता है, that means it was due to defect or deficiency of intrinsic factor that the radio labeled B12 was less in the urine, right? So I hope it is clear all the important aspects of megaloblastic anemia. I hope all they are clear.